Good evening. My name is Regina Francis Makwabi. I think I'm loud enough. Can you hear me? I would like to welcome you all into today's AHN Nephrology webinar, series number 16. My name is Regina Francis Makwabi. I'm the consultant physician and nephrologist working with Africa Healthcare Network in Tanzania. Our today's topic is an integrated multimodal approach to CKD, chronic kidney disease management. It's a great honor to introduce our today's speaker, who is Professor Kamyar Kalantar. Professor Kam is a tenured professor of medicine, public health, epidemiology, and nursing sciences, University of Irvine, College of Health Sciences. He's also a chief division of nephrology, hypertension, and kidney transplantation, School of Medicine. He's adjunct professor of epidemiology, UCLA, Field School of Public Health. He's also an editor-in-chief, Journal of Renal Nutrition. And Professor Kam has published over 900 scientific articles and authored many chapters and presented over 500 abstracts in national and international conferences. Professor Kam, we have audiences from all over Africa and outside Africa. So you are warmly welcome. As you stated, you'll be having a 1-hour presentation. In Swahili, we say karibu, so you're warmly welcome, and we are ready to listen from you. Thank you.
Thank you very much for your kind introduction. There's so many great colleagues. I don't know who to thank for the opportunity. And I hope that we can set the stage for a great platform to work collaboratively. Let me see here. So let's try one more time here, share screen. All right. So an integrated multimodal approach to CKD management. My name is Kamyar Kalantar. And again, I would like to thank for the colleagues for the opportunity to present today. So let me see here. All right. Okay, so also I would like to share with you that I am involved with the World Kidney Day. And the World Kidney Day it comes up with a theme for each year. And I go over this. Also, I represent here, let's go to the next slide. I'm the past president of the International Federation of Kidney Foundations with World Kidney Alliance included. And the International Federation of Kidney Foundations, World Kidney Alliance, is the co-founder of the World Kidney Day. And World Kidney Day is an important event. It symbolizes and solidifies our goals towards unifying our important objectives to increase education and awareness about kidney health and kidney disease. Every year in the past 5 years I've been involved, there is a focus or a theme on the World Kidney Day, as you can see here. Kidney disease in children, in women, women's health. Last year was kidney disease prevention. This year, the theme of the World Kidney Day is living well with kidney disease, which we continue to celebrate and to acknowledge. And next year, 2022, will be kidney health for all. So this is now the year of kidney, living well with kidney disease. That means if you have kidney disease, you should be assured to live well and long with kidney disease. There is no reason for a person with kidney disease to feel that he or she is different. And that's what the International Federation of Kidney Foundation and ISN, the two co-founders of the World Kidney Day, are committed to. Also, today's presentation comes from these 4 textbooks and a number of papers I've contributed to. Objectives are defining conservative management of CKD, examining differences and similarities between supportive care and kidney-preserving therapy, and understanding certain dialysis modalities. So when a person has chronic kidney disease, CKD, it affects daily living and quality of life. And we, all healthcare providers, including nephrologists, nurses, dietitians, we are here to ensure this one. Let me highlight it: to advance research, practice, and policy related to living well with kidney disease. There is an increasing recognition of the need to identify and address patients' priorities, patients' values, and patients' goals. As you notice, I repeated patients 3 times. Why? Because if we are disconnected from people we're supposed to serve, if we are going to tell them what to do and what not to, without we understanding what they want, then I think we may not be as successful. So now I would like to share with you this chart. I published this last year at this time in the New England Journal of Medicine about how kidney disease progresses. As you can see here, as kidney disease progresses, eventually, since chronic kidney disease is reversible, it reaches the stage where patient needs dialysis. So in the past, we used to say earlier dialysis is better. If you remember, until a number of years ago, we used to say that we should put efforts on dialysis. And then that led to overreaction. And now we're in a way, in a phase where we say dialysis is not a good idea. Let's just avoid dialysis. And if patient needs dialysis, just tell them dialysis causes more suffering. So here we are, again, going from one extreme to the other extreme. And the recent era is supportive care. There is nothing bad about this if it is done correctly. But this is not for everybody. This is only probably for a very small number of people who have so many other problems, like advanced cancer, comorbid diseases. Otherwise, the supportive care has also its own value. Life-sustaining care is an important approach, but this cannot be only done by earlier dialysis. And here we are with options, how we can have a balanced approach, a multimodal approach across these 2 extreme cases. And there is increasing recognition of palliative care, which also includes no dialysis or stop dialysis. But as you will notice, there is a lot of emphasis on symptom management to team up to ensure that patients don't have suffering. Look at these symptoms. You may say this is very basic. Yes, this is the basic approach to our field. Symptoms related to chronic kidney disease and uremia, pain, fatigue, pruritus, fluid retention. Now, if you look at here, a colleague in Australia, Dr. Alison Tong. Dr. Alison Tong did a number of studies, patient-based, qualitative studies, focus group. And what she found is here, look at here. Let me just again highlight here, ability to travel, dialysis-free time. No matter where the patient is, this is what they prefer. A patient does not necessarily want to have dialysis every day. A patient is a person, a patient with CKD, and he or she would like to be treated as a normal person. And we're here to give patient hope. Now, why hope is important in CKD? Because it's the foundation of patient and care partner empowerment. Hope is a feeling of trust. Hope makes patients feel more powerful. And this is our job, to ensure that we provide patients with a platform, with the background that to enforce hope. And therefore, we decided that 2021 is the World Kidney Day's theme of living well with kidney disease, empowering patients and their care partners. I don't say caregiver, because caregiver sometimes is a person who is receiving money, but a care partner is a caregiver who is a member of the family or a friend whose life is also affected by the kidney disease of the patient. So that person becomes care partner. And this is the new concept that they want us not just to call caregiver, but care partner. It's a partnership. And if you look at here, there must be clinical strategies for living well with kidney disease. Preserving kidney function. Let me highlight this one, patients-friendly lifestyle and diet. This is something I'm going to highlight also in a few minutes. Delay dialysis start if possible. So tell the patient dialysis is important. We're going to try to bring resources to this place, to that place. But dialysis is like chemotherapy for cancer. It's not the usual way of treating. This is the ultimate last resort. When it's necessary, like chemotherapy, it will save lives. And we're here also when a patient starts dialysis to preserve kidney function on dialysis. This is called residual kidney function. All right, so let's go over this again, hope. So next year, 2022 and 23 will be 50 years anniversary in the United States, where I am in California. In the United States, the 50 years or half a century anniversary of dialysis for everybody. And dialysis, yes, dialysis has brought hope. Hope of continuing valued relationship, because patient without dialysis most likely would not survive. Hope for rehabilitation, hope of achieving life goals and pursuits. It's an example of a patient. I apologize if this is somewhat disconnected with realities of some other regions of the United States and other countries. But this patient at the age of 71 was supposed to die, and he became an advocate for dialysis and lived until early months of COVID. So for 8 extra years on dialysis, and he was a proponent of dialysis, and he was saying dialysis means life. He created late Mr. Alan Henry to say that, hey, dialysis, if necessary, if it's done correctly, it also is an important option. So now let me go over the treatment choices. So choice is the important factor to enforce hope. We talk about hope. Hope cannot be unrealistic. Hope is based on choices. Now, when we talk about choice, not infrequently, we think having 2 options is enough, good or bad, this way or that way. But this is called dichotomy. Dichotomy is a limited choice, is not a real choice. Real choice would be I give more than 2 options, not either this or that. I give the patients that you have beyond preserved dichotomy. Look at here, conservative and preservative management, expanded use of palliative care. Palliative care is not for the just one-way direction of dying, but on the contrary, to live longer. Gradual transition to dialysis. This is something that has started coming to the United States, the land of dialysis, and now we have questioned everything we have done, and we learn from other countries, including India and China, to do gradual transition to dialysis and then palliative dialysis. So now, let me share with you that in the past, in the United States, we used to say for old people, the choice should be limited, maybe delay or defer or avoid dialysis. But even in the United States, we have come to believe that this is not for old people. This is for everybody. To start dialysis as soon as possible is not the best option. Just because I don't have a dialysis machine doesn't mean that the moment the dialysis machine becomes available, I offer it to everybody. No, actually. And that was wrong what we did in the United States for 40 years. And we have come to believe that dialysis, like chemotherapy, needs to be offered at adequate dose, sometimes very small doses, sometimes daily dialysis. So it differs across different patients. Now, going over the expanded options. Instead of dichotomy, going over conservative and preservative management, gradual transition dialysis, expanded use of palliative care, palliative dialysis. Now, if I highlight the first one, conservative and preservative management, and I've highlighted here the keyword diet. And once again, the New England Journal of Medicine kidney chart, preservative management, symptom management, palliative care, lower part is life-sustaining, upper part is supportive care, and here highlighting preservative management. So preservative management or kidney preserving therapy, according to the paper we published last month in Lancet, is a life-sustaining type of conservative management. That means conservative management does not mean that, hey, I avoid everything and you go to the path of dying. No, the correct inclusive definition is that it includes also kidney preserving therapy, prolonging dialysis free time, and achieving the greatest survival. And how can we do this? Either pharmacologic agents or non-pharmacologic agents. So there is no magic pill that I give to the patient and says, hey, take this once a day, twice a day, and you will never have kidney failure. Your kidney disease doesn't get worse. And there is also no magic diet that said, hey, if you eat this, your kidney disease disappears. So if you look at conservative management without dialysis, it's not just for the old people, it's for everybody. In 2021-22, it should be for everybody. And now expanded, a new version of the New England Journal of Medicine chart, kidney chart, is the one that we put in the Lancet paper a few weeks ago. And we said that kidney preserving care means slowing progression, preventing, delaying dialysis, and improving cardiovascular risk. Because a lot of kidney disease patients, they have cardiovascular risk. And also, not to forget symptom management. That means patients who start dialysis, not infrequently, has more symptoms, more pain, more cramps. And it's wrong to believe that by offering dialysis, our job is over, or by offering kidney transplantation. No, on the contrary, we may introduce more problems, more symptoms, unpleasant symptoms. And palliative care and hospice medicine has its own niche. Whenever it's necessary, we use that. Now, let me go back to kidney preserving care. Kidney preserving care could include diet and lifestyle modification, but also pharmacologic agent. This is the multimodal approach. It's similar to cardiologists. I'm sure colleagues who work with cardiologists, good cardiologists, they don't say take this statin, lower cholesterol, and you're done. They say take cholesterol managing agents and change diet and lifestyle. So both of them at the same time. And if you want to preserve kidneys longer in those with early kidney disease, earlier kidney disease, and later kidney disease, we need to appreciate the primary goals of kidney preserving therapy. That means slowing progression. Of course, everybody agrees. There's no question about this. To achieve the greatest survival. So this is to improve survival and effective treatment of renal and non-renal comorbidities. Now, I told you guys that every year there is a theme for the World Kidney Day. Last year, 2020, the World Kidney Day's theme was prevention of kidney disease, but there is also secondary and tertiary prevention. Remember, primary prevention is great, but we nephrologists or kidney care providers, we see patients usually when they already have kidney disease. So it's good to talk. We have to be a little bit careful when we talk about kidney disease prevention. If in front of you there is a patient who already has kidney disease and we talk about prevention, you may even hurt the feelings of that patient or that family member. Says, hey, doctor, thank you for talking about prevention of kidney disease, but I already have CKD stage 3, 4. What should I do? Then it's called secondary prevention and tertiary prevention. So secondary prevention now, according to World Kidney Day, is slowing progression. That means early kidney disease to slow progression, delay dialysis, and tertiary prevention is a more advanced kidney disease to prevent dialysis initiation. And I've highlighted here the keywords, but also diet and nutrition. And conservative preservative management is to slow progression. Now, in the United States, quite interesting to know that in July of 2019, the previous US president came up with a new executive order that by 2023, United States should have 25% less kidney failure than is end-stage kidney disease. So if the United States wants to go to that direction, the place where there are all dialysis modalities and dialysis machines available, so you can think that this is probably a good way to do it. And it's definitely a good way to do this. To delay and defer dialysis initiation is always good, and it's never for only old people, it's for everybody. And therefore, I'm highlighting again, reducing number of Americans developing end-stage kidney disease by 25% by 2030, which is 8 years, 9 years from now, improving efforts to prevent, detect, and slow progression. And if I highlight here clinical strategies, once again, remember patients-friendly lifestyle and diet. So now, colleagues who remember certain things, they said, Dr. Kalantar, the diet never works in kidney disease. Why are we even talking about that? Yes, there was a landmark study which was published in a study was conducted in late 80s and early 90s called the MDRD, Modification Diet in Renal Disease. And the study, when it was published in 1994, New England Journal of Medicine, says that diet doesn't work. And at that time, what was the diet? It was low protein diet, low protein. And you may say that, hey, in many parts of Africa, we already eat low protein. Well, let's delve into this and see what happened and why low protein. This is essentially the main result of the study. One of the two parts of the study was comparing normal protein, which is high protein, with low protein. And after 3 years, 36 months, there was some slowness in the progression of low protein diet, but it wasn't significant. So therefore the study was negative. Now, this study did not include diabetic patients. It was less than 3% and excluded anybody who was on insulin. Polycystic kidney disease patients were 24% of the entire study. So these are very slow progressive CKD patients. Let me remind myself of importance of kidney physiology and the importance of glomerular pressure. So this is something that a number of colleagues 30 years ago, they discovered, still a hypothesis, that the reason CKD happens is increased glomerular pressure inside glomeruli. And if you want to slow progression, you have to give ACE inhibitor and ARB to open efferent arterioles, right? To lower blood pressure, or nowadays SGLT2 inhibitors to tighten afferent arterioles. But it's very interesting to know, if you want to maximize lowering blood pressure in the glomeruli, as shown here, I can also use less low protein diet. Why? Let me share with you what's happening. Those who are eating a lot of meat, and those who feel that now that I have access to meat and red meat and chicken, I have to eat as much as possible. Increasing amino acid surge in the blood within 30 minutes of eating high protein leads to opening afferent arteriole, increasing intraglomerular pressure. So that is something that I don't think anybody would question. Now, let me share with you real data from human volunteers, those with diabetes and non-diabetes. Already in 1991, Dr. Tutel showed in patients with diabetes, when they infuse amino acids, GFR goes from 95 to 165 within 30 minutes. This is called hyperfiltration, glomerular hyperfiltration. It's a physiologic, evolutionary mechanism. Why? Because kidneys are there to overwork when you eat protein. And even in patients without diabetes or person without diabetes, hyperfiltration exists. This is evolutionary. This exists in dogs and rats and carnivorous animals, actually. The GFR goes to 200, 300 each time they eat meat. And in human being also it goes, as you can see, 30, 40% higher or 60% higher if you have diabetes. So imagine you have now a diabetic patient with CKD and you tell the patient eat a lot of meat to lose weight. So you may cause even more harm by doing this. And that's why we say in diabetes, CKD progression is faster because not infrequently they are told they eat more protein to lose weight, which has a value. But this is essentially here the question. Are we causing more harm by telling these patients to eat high amount of protein? Or bodybuilders. I have bodybuilders in Los Angeles from Hollywood, but these are essentially, they make money out of making muscle and being security guards, former US Marines. They retire at the age of 45 and some of them, they have chronic kidney disease and I cannot save them. Some of them are on dialysis, high protein nephropathy. Now, what happens for those who eat less protein, not starving, look, less protein, and we're gonna talk about this. What happens, their GFR is lower. So that was the concept 70 years ago, 30 years ago. And this is an integrated multimodal approach. How I can lower blood pressure inside glomeruli. One way is low protein diet and low salt diet, restricting sodium intake, but also medications. So now you can see here in this Lancet figure 2, what we put together, both diets, lifestyle, and medications together, not one versus the other. And that's the approach that probably works the best. We don't have a clinical trial yet. These are based on fragmented studies. If you look at now MDRD study, initially, the first 3 months actually, GFR got worse in those with low protein diet. But then if study had started from month 4, the study would have been considered positive. And this is similar to SGLT2 inhibitors. If they're available or they come to Africa, we're not using them even in California as often yet, but that's the same approach. All right, so now, what about fear of malnutrition? That is really less likely to happen because we are not saying starving with very low protein diet. We say low protein or avoid high protein. That's what I also tell my patients who donate a kidney to another person. I say, hey, you have one kidney. I appreciate you giving your kidney to your child, to your husband. But I want you to be careful for the next 50 years of your life because you're going to live hopefully 100 years, but avoid too much red meat and avoid obesity, check blood pressure control. So we have now a program for those who donate kidneys or kidney cancer. Now, well, how much protein, have you ever thought about this? How much protein do you need? Recommended dietary allowance. In the United States, Institute of Medicine has suggested that all you need is 0.8 grams of protein per kilogram per day. Indeed, studies have shown that all your body needs to avoid protein loss or muscle loss is 0.46 or 0.5 grams of protein per kilogram per day. But the Institute of Medicine of National Academy of Medicine or National Academy of Medicine has suggested to go up to 0.6, and then 0.6 to 0.8 is the safe margin, and 0.8 grams of protein per kilo per day is the target. So if you are 80 kilograms, roughly it's around 60 to 70 grams of protein a day. But that's not even low, that's normal. However, since we all eat a lot of protein, because we feel that now that meat is available, we should only eat that, we eat above and beyond this. What about the not quantity, but quality, protein from animals versus protein from plants? Have you ever thought of that? Plants have also protein. Which one is healthier? If you eat more legumes and fruits and vegetables, they also have protein. Now, Dr. Nayak from India presented this during a session a few weeks ago. He highlighted a study from UK by late Dr. Contessis, who is not here anymore, who passed away 2 years ago. What he found comparing animal-based protein to human protein, to plant-based protein, if we switch same quantity from animal-based to plant-based, the intraglomerular pressure goes down. You remember intraglomerular pressure to preserve kidneys, right? So, and then in addition to these amazing animal models, there are also human epidemiologic models that this Dr. Srini Bedu from Salt Lake City, what he showed, if the proportion of plant-based in the protein of your daily food is higher, above 50, 60, 70%, the higher is protein coming from plant versus animal, the lower is mortality of a CKD person. So we have come up with this concept of plant dominant, instead of saying plant-based, because plant-based means to become vegetarian. We say plant dominant, that means PLA plant, DO dominant is called Play-Doh diet. Play-Doh diet is a low protein diet, 0.6 to 0.8, but more than 50% of the source of diet comes from plant. The other 50% can be your choice of chicken or fish or whatever healthy animal food you have, some dairy products, low salt diet, high fiber. And so this is essentially the approach to Play-Doh, which is very similar to DASH diet, and highlighting culinary medicine, that means food as medicine, and telenutrition, telehealth. Nowadays that COVID is, the entire planet is affected by COVID. Now, if I could, I'm going to stop talking about the diet and lifestyle, because I want to talk in the next 15 minutes about everything else, and then we're done. One is that the IFKF in 2016 in Malta, we had a conference about conservative and alternative approaches to CKD management. I talk about the diet, but look at here, giving more diuretics, or look at here, intestinal dialysis. This is something that's the past become future. And also diaphoresis, sweating. So now in Africa, I would like to ask you guys to be, as you guys are innovative, to look at these options, because they need to come to all countries around the world. And if you look at here in 1951, before dialysis was widely available, this was an approach about intestinal dialysis. Essentially, it's very simple approach. Diarrhea. When my dialysis patients have diarrhea, I tell them not to come because your diarrhea is already dialysis. You having watery stool today, you already did your dialysis. And most patients also decide not to come to the dialysis unit when they have diarrhea. So there are so many data about this. I'm showing only one slide. I would like to stimulate your thoughts. I think there are some companies opening in China and in Dubai about intestinal dialysis or dialysis or bowel as kidney. So please look this up. The other one is diaphoresis, sweating, as also alternative to dialysis for both fluid and electrolytes, potassium. As you know, for both diarrhea and sweating, potassium volume goes down. So these are, I'm just sharing with you these two slides because I would like to move on with the rest of my 10 minutes so we have time for question and discussions. All right. Now, the last 10 minutes, I'm talking 2 to 3 minutes about each of the other choices. Choice 2, gradual transition to dialysis. And you may say that, what is this? Well, guess what? I learned that in South India, in Shanghai, China, that patients are receiving once a week to twice a week dialysis. In the US was taboo in 2012. When I went back to the US and tell the colleagues that we need to do that, what does it mean? It means that if a patient needs dialysis, let me highlight, gradual transition to dialysis. You do everything, your patient lasts 5 years longer without dialysis, but eventually your patient needs dialysis. And if I go back to this kidney chart from Lancet paper, I'm now highlighting incremental transition to dialysis and preservation of residual kidney function after patient transition to dialysis. Now, why is it important? I can give you 1 hour talk just about this. If your patient starts dialysis, please make sure patient continues to urinate. residual kidney function. Half an hour to an hour just talking about benefits of patients maintaining residual kidney function. In peritoneal dialysis, it's a big deal. In hemodialysis, sadly, we forget, even colleagues in peritoneal dialysis forget to help preserve residual kidney function. How can you do this? Medications, but also incremental dialysis, also low protein diet on non-dialysis days. If I could highlight this with you, the old option in the US was, and still in many East Coast areas of the US, is to start suddenly 3 times a week dialysis. Now in Southern California, as well as in many other places, the current approach is to start patient on twice weekly dialysis first. And I would say, according to Shanghai and Bangalore model, we should start them on maybe on once a week dialysis. And then when patient needs more dialysis after 3 months, 2 years, 3 years, who knows, the patient body decides, switch from twice weekly to thrice weekly. And then maybe 10 years later, 4 times a week, if patient doesn't get transplant, and then at the end, adjust all these doses. So this is the concept of incremental dialysis is very important nowadays. And I don't have time now to share with you that on non-dialysis days, we also offer low protein diet. That means on dialysis days, high protein diet, non-dialysis days, low protein diet, again, multimodal approach. All right, so, and then I would like you guys to read more about gradual and incremental dialysis approach, because this should be probably the approach to anybody who needs dialysis. Don't think to start 3 times a week is the best thing. Of course, if a patient was delayed and is very uremic, probably 3 times a week is needed the first few weeks, and a patient after 2 or 3 weeks still makes urine, then try twice a week and see if it works. But don't think that twice weekly is forever. No, actually, it's for the start, or as long as the patient makes a lot of urine, residual kidney function. Next topic, expanded palliative care. Palliative care is not just to die. Actually, on the contrary, palliative care is for this, living well with kidney disease, expanded use, symptom management. Dialysis patients, they have a lot of symptoms. Non-dialysis patients, when they are uremic towards them, they have pruritus, fatigue, pain, starting dialysis with cramps. So symptoms, unpleasant symptoms, they overshadow what they have. And there is a new field in medicine called symptom science. This is not symptomatology that we learn in basic medical school. This is symptom science. It means clusters of symptoms. That means one symptom often exists with other symptoms. For example, if your patient has pruritus, itchiness leads to agitation, mental health issues, depression. Patient cannot sleep, therefore sleep disorders. Patient perceive pain more. So one symptom has clusters of symptoms. And this could be regardless of those of dialysis or kidney transplantation. You may say, hey, I'm giving you dialysis, don't complain anymore. But there are so many reasons that patients continue to suffer, right? And we are here to help them with their fatigue, depression, lethargy, pain, pruritus. And therefore, World Kidney Day 2021 also put emphasis on symptom management, how we can team up to ensure that these symptoms are covered. Not to say that since we are giving you dialysis or you have a kidney transplantation, our job is over. Look at here, fatigue, sleeplessness, pain, or being tired, pruritus, these are important causes of suffering. A lot of patients, they stop dialysis and die. They say, I can't live like this, right? So this is important. So let's not forget, in addition to divisive medications, we need to focus on symptom management and highlighting again important symptoms: dry skin, feeling trouble falling asleep, having less energy, and muscle cramps, constipation. So all of these may cause more suffering than original kidney disease. And if you look at here again, Song study, fatigue, cognition, depression. When patients were asked, what do you prefer in life? Ability to travel less dialysis, please help me with my fatigue, with my cognition, with my depression, and I want to have ability to work and to study for younger people. And again, highlighting symptoms. This is also, we have a conference on December 2nd on on unpleasant symptoms of CKD patients. Let me know if you're interested. And then if you have people on dialysis or kidney transplant, at some point kidney transplant fails, right? By that time, patient may be very old for dialysis. So choice number 4, palliative dialysis, gradual adjustment. So that's essentially the opposite of incremental dialysis. Sometimes we call this, let me highlight this here, less dialysis. That's where I said there is an important value for palliative care. And this is actually this area, decremental dialysis, right? And this is the ultimate precision medicine. Precision medicine, I mean, this is called precision dialysis. Dialysis is not 3 times a week for all, one size fits all. So altogether, these are choices we give to our patients. And I would like to ask you, when you make a decision about continuing dialysis, be careful if your country has some of those perverse incentives. That means, for example, in the United States, sadly, we are fighting against this requirement that patients who are, if a patient comes back to the hospital within 30 days, the hospital is penalized. This is called 30-day readmission penalty. And that has led in some United States hospital, when a dialysis patient comes here, when they think this patient is too sick and is going to come back, they convince the patient to choose the path of hospice and to stop dialysis, which I feel is wrong, because we are sometimes the last advocate that the patient has, right? So when patient is sick, when the patient is hospital, this is the worst time for the patient. I, as nephrologist, even if family members of the patient convince the dad or mom that mom, it's time for you to die, just stop dialysis, you need to go to the patient and continue to give hope, right? Because patient has heart attack, dialysis patients are sick. Suddenly they have chest pain, they have heart attack, they have pneumonia, they have COVID. So we need to make sure that they're not forced to end their lives because of resources. We are probably the only advocate they have, not even family members. So, and these choices hopefully help these patients. So now in summary, this is the last 4 slides, living well with kidney disease conclusions. If you notice, I talk about so many areas, from diet to lifestyle to medications to kidney physiology. In India, where Dr. Lloyd Vincent is coming from, there is a 3,000-year-old doctrine of when diet is wrong, medicine of no use. So let's first of all continue to focus on diet and lifestyle. And in International Federation of Kidney Foundations, look up ifkf.org. We now have come up with the new project, World Kidney Recipes. We would like multicultural recipes. And you may say, Dr. Kalantar, you said meat is bad. I never said meat is bad. I said that less meat, right? And same way when people say, for example, potassium is bad, and to the point that some patients are so scared even looking at fruits and vegetables, I said that's wrong. World Kidney Recipes means we team up to come up with meal plans from different cultures. Instead of telling patients not to eat, to come up with amazing recipes so that we make the journey of CKD enjoyable. We work together in these recipes. This is an open book for all of us to contribute to this. And so join us with this, with the International Kidney Foundation World Kidney Alliance. And now I would like to also, from California, to quote Miss Lori Hartwell, who is my age, mid-50s, and she started dialysis at the age of 5 with 3 kidney transplant dialysis. And she says, don't dialyze, don't live to dialyze, dialyze to live and enjoy life. And again, dialysis means life if it is given to the patients at correct dose, correct frequency. Don't overdo dialysis just because suddenly dialysis machines are here in this part of the city, everybody goes there. And always remember that despite all problems, dialysis means hope. Dialysis, despite all its flaws, dialysis, people who choose to start and maintain dialysis, they have that choice, and we are there to enforce the choice. So in summary, in patients with moderate to advanced CKD, the main goal should be to prolong and preserve kidney and patient longevity. Delay dialysis as long as possible, and this is now the goal in the United States. Nutritional interventions are important, notwithstanding that many nephrologists from US and from Germany, from especially Europe, when they come to tell you that nutrition doesn't work, actually it does work. It is there. There is no reason for us to say no. And when patient needs dialysis, start incremental dialysis, gradual dialysis, preserve kidney function, conservative and preservative management. There is an urgent need for us to pursue conservative and preservative management. That means incremental dialysis, effective symptom management, palliative dialysis. And the World Kidney Day 2021 is about living well with kidney disease, ensure patients do not continue to suffer from unpleasant symptoms. Patient and care partner needs to be empowered. Life participation, which is another concept I didn't talk about. This is beyond quality of life. That means how bring the patient back to life. I share with you a few slides from some study. I want to contribute to society, not to be a disabled person on dialysis. And let's team up for our patients to feel well and supported. So with that, I would like to acknowledge colleagues at the University of California, Irvine, and University of California, Los Angeles, where I work, and also International Federation of Kidney Foundation. My social media, Twitter, Facebook, LinkedIn is at Kamyar Kalantar. And thank you very much again for the opportunity. Living well with kidney disease. Continue to acknowledge kidney disease for the rest of 2021. And also International Federation of Kidney Foundation, World Kidney Alliance. Thank you very much.
All right, Professor Kam, thank you very much. We really appreciate that. Was excellent presentation, and there are a lot of new things that we have learned. I personally learned today. We are going into the question and answers and comments from the audience. Professor Kam, I would like to ask you one question or two. One is the low protein diet, 0.6 to 0.8 grams per kg per day. What about in patients who is on dialysis and actually is anuric? Because would you recommend low protein diet? Because what are we preserving anyway? Because all the nephrons has gone. On top of that, for patients who are on PD, peritoneal dialysis, will also be good to have low protein diet. That's question number one. Question number two is, it was not very clear for me on incremental dialysis, starting from twice a day, 3 times a day, and you said even can go up to 4 times, I mean a week, sorry. So what makes you to decide and going from twice a day to twice a week to 3 times a week? Is there any criteria that you'll be looking at?
Thank you.
Those are my 2 questions, Professor Kam.
Sure. Thank you for 2 questions. So let me tell you, these questions are important because they allow us to continue the discussion. I should really have emphasized that a patient who is on dialysis and doesn't make urine, usually most patients after 1 to 2 years of dialysis, after 6 months actually, most patients after 6 months of dialysis, studies have shown 80% of patients after 1 year of dialysis don't make urine, right? Now, these patients all need high protein diets, okay? Now, you won't be surprised to know that the same Dr. Kalantar who talks about low protein diet, I go to 3 dialysis centers and I pass out burgers during my dialysis rounds to my dialysis patient and say, hey, I want you to eat high protein in front of me. So that's also called precision nutrition, precision medicine. Now, then patient gets confused. Say, Dr. Kalantar, you told us for the entire 5 years I was your patient, you told me low protein diet, now you're telling me high protein diet. I said that, look, first of all, for those who start once a week or twice a week, the Locatelli protocol from Italy and the Japanese protocol, they say continue low protein diet on non-dialysis days and high protein diet on dialysis days, all right? You see how it is? Because dialysis is hypercatabolic. So around dialysis, if dialysis at noontime, in the morning and in the evening of dialysis, eat a lot of protein. If it's only once a week or twice a week, on non-dialysis days, switch back to lower protein. So this is called from Professor Locatelli in South Italy, and they have great data on that. And then if patients now connecting, expanding on incremental dialysis. So right now in Southern California, we start most of our patients on twice weekly dialysis. Some of them also on even once a week dialysis because they make a lot of urine, right? And then this is also a good switch to dialysis because patients initially, they're scared of dialysis. I'm sure you have had patients who say, doctor, I prefer to die than starting dialysis. They think it's a death sentence, right? So if patient is so scared, you start gradually dialysis. Now, the old notion was, hey, we need to dialyze in the hospital every day. Yes, maybe in the hospital, if patient is admitted to the hospital, that's an acute situation. But once patient is stable to be discharged, if you have a dialysis clinic or patient comes back to hospital twice or 3 times a week to be dialyzed, try to see if you can lower frequency to twice a week or sometimes even once a week. And then finally, the last part of your question, who decides when patient goes from once a week to twice a week, twice a week to twice a week? You, nephrologist expert, you decide. There are 10 criteria. If you invite me next time to talk about incremental dialysis, I go over the criteria, but the most important one is residual kidney function. That means you measure, you estimate. Sometimes even in this high resource place, United States, I say all I need is, I need to know what's the urine volume. I can calculate urea kinetics. I measure urea clearance or combination of creatinine clearance and urea clearance. But the easiest approach is to ask your patient to pee for 24 hours inside a large bag. If it is more than half a liter, that's a lot of urine, right? A lot of dialysis patients after 1 year, they just make maybe 1 cup of urine if they're very lucky. I mean, just a portion of this, that's all they make. That's not enough. Then that patient needs at least 3 times a week dialysis, right? So therefore, residual kidney function of your patients, every month ask patients, sometimes I ask my patient, do you still wake up at night to go to bathroom? Nocturia. If they don't have nocturia, that means they don't make enough urine anymore, right? That's a very easy screening of residual kidney function.
Thank you, Prof. Thank you very much. Appreciate it. Can we get more questions and comments from the audience?
What about, thank you very much, Dr. Kam, wonderful. It's a whole spectrum that you covered. I mean, I think there are lots of talks that can go into each of those aspects that you mentioned. Now, one very puzzling aspect has been, see, we go through looking at KT or we look at anemia, we look at calcium phosphorus in bone, we look at nutrition and sort of the physical activity that a patient on dialysis needs to go through. But actually, the patient really has a lot of symptoms. Like, for example, you mentioned pruritus, and tiredness, fatigue. And that has been actually, a question that we actually have ignored. But the other issue is, how do we solve those problems? I mean, yeah, we can go into dialysis, they are on dialysis, but how do you solve these issues? Like, for example, fatigue or tiredness. And pruritus, you go through the whole differential diagnosis of pruritus and you try and answer the question there, but still the pruritus persists. So how do you solve these issues? That is the question. And now I know that there's a controversies conference coming up now, probably in January from the KDIGO, but I think that's a very important concept. And the fact that making dialysis infrequent in the African context, I think it makes a lot of sense, because it's a nice way to start in the African context. So just a broad question, I would like your insight into this.
Yeah. We have actually another conference on December 2nd in Honolulu, which is the capital of Hawaii, and a number of experts are coming. And then in March, we'll have open second part, which is open door 2-day conference on living well with kidney, effective management of unpleasant symptoms. So we don't work with KDIGO, nothing against them, but we have other approaches and conferences. And what we do here, and you're right, to say that, hey, you're saying symptom management, so what is the solution? And the answer is that we are not very effective. We don't have a lot, right? We don't have a lot. So we have missed the opportunity. All these years, all we were focused on, for good reason, was uremia, CKD, uremia, and dialysis and kidney transplantation. But we really forgot to focus on patient suffering. So what should I do with, I have had patients whose pruritus was so massive that patient decided to die. Says, doctor, this life is not worth living because all I feel day and night itchiness. At night I can't sleep because of that. And I feel sometimes I fail these patients of mine. I should have been more effective. I don't know what I should have done, but I wasn't effective. And I wish, and nowadays there are some medications. We're going to talk about options, medications, and how we can actually, if colleagues are interested, how to bring them also to African countries, for example, for anemia, for fatigue and other things. So this is, again, where the multimodal approach could help, not one pill or one silver bullet, and more talk about changing lifestyle and everything else. I see that one of the colleagues has raised hand for a question.
Yes, Dr. Bhima.
Hi, Dr. Kalantar. Thank you very much for that really inspiring talk. And I must agree with you that in our setting, in poor resource countries, incremental dialysis is something that we practice all the time as a cost-saving measure more than doing it in a way that you have put it. But that's not my question. I am a pediatrician, so I apologize for that. When it comes to diet in children, it's very difficult to control that because children eat what they want to eat rather than what you prescribe to them. And so it's a problem that I have because dietitians come across and they say, well, you've got kidney failure, so we're going to restrict protein. And they do that across the board in every patient, not knowing that actually this is not a practice that should be done, but should be done only, as you said, in the days that the patient is not on dialysis. Now, I think our emphasis should not only be on nephrologists, but also on the ancillary staff, etc., so that we can educate them about this and tell them that we should not strictly restrict protein on all these patients. Yes. In children also, you have growth that is very important. So you have to balance growth against the kidney function. So what is your take on that?
Yeah, first of all, I'm very proud to see my pediatrician colleague. I'm also a board-certified pediatrician, so that you know. I'm both internist and pediatrician, and you should be very proud to be a pediatrician. Can I ask which country you are right now? Where are you based?
I'm from South Africa.
South Africa?
Yes.
Yeah. Professor Rajendra Bhima comes from South Africa. He's a pediatric nephrologist. Yeah, so it is because for each 10 adult nephrologists, for each 10 to 20, there is only one pediatric nephrologist. So it's so difficult in the United States, California, anywhere else, for to find pediatric nephrologists. They're very precious experts. So thank you for doing what you're doing. That's number one. The second thing is that you are so correct. This is essentially the ultimate precision medicine. When
patients, actually, they ask me, because we have a pediatric dialysis center next to our hospital, in a different hospital, and not infrequently they ask me to cover. I mean, so sometimes they ask me to cover, and I always discuss this, that, hey, a child needs more protein. Even Dr. Kalantar, who says less protein for non-dialysis patients, I say more protein for a person who is going through puberty. It's called failure to thrive, right? Failure to thrive, as Professor Bima knows and teaches probably, is very common in CKD in children. And they need adjusted approach to that. It's similar to some of my patients. I'm going to now go to an extreme example. These are bodybuilders. They make money. They are bodyguards of Hollywood stars in Hollywood. They say, Dr. Kalantar, you're crazy. You tell me low protein diet. I need 300, 250 grams of protein a day. And I sit down and calculate to come up with an estimate. Since you are in this anabolic goal as a child who is growing, you need to adjust the amount of protein for that, not to go much higher than that, not to go lower than that. So therefore, we look forward to more work and case reports by Professor Bima to that direction, so that we can work together to ensure precision medicine. Because remember, I also keep saying one size fits all is wrong. Most adult patients with CKD may benefit from low protein diet, but not everybody. And we need to adjust that. Also, when I say plant-based, 50% based on plant, I have had patients whose potassium is out of control. Here in the US, we use potassium binders. And then even I lower the amount of sometimes plant. I say that please avoid dry plants and dry fruits, because they have more potassium and other things. So we need to maintain precision medicine. Precision medicine, or individualized, means individual's approach. We say that it works with low protein diet, low salt diet, but not for everybody, and especially for children and certain adults. Or similar to another example, a.k.a. When a patient goes to a.k.a, right, the CKD patient, CKD 3B or 4, suddenly goes to a.k.a because of something, you say sepsis. This is where you stop medications and diet. I said no more low protein diet, no more ACE inhibitors and ARB. Wait until a.k.a improves, and then we bring back all those. All right.
I'm sorry.
So that was a very good discussion. Thank you.
Thank you very much. Professor Kam, can you go through the chat box and then see the question, a few questions there.
Okay, so let me go to the chat box here. So is it fine to restrict protein in early stage of CKD? The answer is probably yes, or I would put it this way. We say now, avoid more than 1 gram per kilogram if you have very early stages, such as albuminuria, and go to 0.6 to 0.8. So essentially 0.6 to 0.8 for those with CKD 3B or A2, A3 albuminuria, for A3, that means having albuminuria above 0.2 grams a day. And if you have A2 or A1 and earlier stages, 0.8 to 1 probably is a better target. And so if there are patients, for example, in the US or maybe also in your country, there is a surge that they think it's fashionable to eat a lot of meat. If that's the case and your patient has kidney disease, I would usually tell them, please go back to moderation, right? And in all studies have shown that the amount of protein is associated with intraglomerular pressure. If you believe in physiology, that intraglomerular pressure could determine if the kidney is going to, it's like a car. If you use the car very often, if you load the car all the time, that car is not going to last long enough, right? And you may say, what about the history? In the history, of mankind, hunters, gatherers, right? But at that time, life expectancy was only 30 years, 40 years, not even 40 years, right? Now we all want to live 50, 60, 70, 80, 90. So we need to be careful with the longevity of our kidneys. And that's the question. Another question here, nicotine patches recommended for patients, difficulty in smoking. That's a good thing because smoking is also considered a risk factor for kidney disease. And that should be recommended if that's an effective way. Antihypertensive to be avoided in late CKD. That's a very thought similar question. Because people say that we nephrologists, for example, we say ACE inhibitors and ARBs, and nowadays SGLT2 inhibitors, but then when a patient has a.k.a. or more advanced CKD, we stop those medications. Is it good or bad? There are data on both sides. I personally, I look at the patient and I say that, look, some data have shown that in later stages, very low blood pressure is as harmful as very high, right? Notwithstanding spring data saying systolic blood pressure below 120, when my patient has stage 4 and 5, I try not to go too low. Why? Because a blood pressure that is on the low side can easily put the patient in high risk for a.k.a., right? So this is where you need to continue with good kidney perfusion, renal perfusion. There are mixed data. It's very difficult to really pinpoint what is the best. Just you look at your patient and you decide when blood pressure treatment is becoming excessive, then cut back on them. That's one of my things that I do yesterday in my very busy clinic. Quite a few patients, I removed their blood pressure medications because I noticed that I'm causing more harm. So I think I covered, we had 20 minutes of discussion, so that was excellent. So if Dr. Lloyd and others—
One last question from Rwanda.
Oh.
One last question from Rwanda.
Okay,
yeah,
please.
Thank you very much, Prof, for this interesting discussion, which has actually brought in maybe quite a lot of new things. Particularly, I think what seems to be interesting is the issue of incremental dialysis. And I think it is going to bring in, a few dimensions concerning really by how much should one reduce dialysis vis-a-vis the kidney function. I think it is the catch question. The residual kidney function here, it is the catch issue. Now, the original recommendation by both KDIGO and the KEDUKI is the KT of 1.2 per session, and therefore per week should be like 3.6. That's what is recommended. But this assumes a state of anuria.
Yeah.
Now, of course, this seems to now to bring in now, one should also decide, okay, do the KTOV for that urine that one produces in a week. Because at this stage, it is going to become very difficult now for doctors to decide when should I give this patient, well, one or two sessions a week.
Let me tell you, this is such an important question. Why? Because we deal with that every day here in California and other parts of the US, because as incremental dialysis has been on the rise in the past few years, there is also some incentive question, because dialysis providers, they have done a great job, these big companies, but if a patient gets more frequent dialysis, there is more reimbursement from the US government to the dialysis company, right? So there is some conflict of interest here. And then they say that KTRV of 1.2. Now, the good news is that we are working with the guideline bodies and the government of US, and you should do the same with everywhere else, that KTRV is important. Why? Because we need to make sure that patient is not under-dialyzed, right? Because Dr. Vincent will tell you that in old days in India, a lot of patients, since dialysis was expensive, it was 2,000 rupees per treatment, they had to pay cash to get dialysis, right? And therefore, they were getting, even when they had no urine and extremely uremic, only once or twice weekly dialysis. But that's the extreme. On the other side of the extreme is a patient who makes so much urine, and you should really take advantage of residual kidney function based calculation. So a few keywords, KRU, right? K of residual urine. So you do the calculations. It's not very difficult, actually. It's very similar to GFR and urea clearance. You add this, you convert it similar to PD. If you look at the PD literature, there's a lot of great approaches to adding residual kidney function to the dialysis KTRV, adding up, documenting, and says, hey, right now, my weekly KTRV is good, 2.1 or 3 or 2.3. And my patient is happy, doesn't have symptoms, go home with twice weekly, but then every month, every 3 months, make sure you don't lose control. Because when we do a lot of twice weekly dialysis, I've had patients that suddenly are retaining fluid. So what's the most common cause of transition from twice weekly to thrice weekly? Kidney function getting worse, patient retaining fluid, hyperkalemia getting worse, patient going to heart failure exacerbation. So we need to be very careful. So incremental dialysis actually is more work for nephrologists because you need to watch them very carefully now, right? And you do that and calculate this together and everything hopefully works the best. And we learn from you guys. That means you guys don't always look at US and Europe as the source. It's wrong. Actually, a lot of things are you're practicing, and I need to come and see what you're doing from your creativity and innovation and learn that and bring back to the US. So I think, yeah.
Certainly, okay,
right.
you shed more light on this matter again, because you mentioned about the US government. But here we also have got, insurance companies who might, if that one drops into areas, most of their medical advisors, they're not even nephrologists. Most of the time they are GPs. So they might actually decide now, okay, now we shall be paying for 1 or 2 dialysis per session. But the issue of kidney function actually is very important. I have got one very good example. I have a patient who we started him on dialysis. It's about 3 or 4 years ago. Now, this fellow, somehow he ran short of funding. He was having 2 dialysis per week, but then he decided to go home. He comes 3 months later in coma. We start him on dialysis. Again, he wakes up. Now, we are dialyzing him twice a month for the last 3 years. So
I'm sorry, did you say twice a week, right?
No, twice a month.
Twice a month.
For the last 3 years, we are dialyzing twice a month.
Excellent. Look, let me tell you, let me just stop you and ask you.
The importance of residual kidney function is actually,
This twice a month case needs to be published. I'm going to ask you to sit down because I found once or twice a month patients also in both South India and in China. And I told them, please write down your case, describe them, and email me. I can get your paper to be published in one of the good journals, because we need to learn from those cases, all right? We need to show to these somewhat what I call arrogant United States and West Europe that dialysis is not just the way that they tell us, right? Dialysis could be done. Your case, we need to learn from you. So with that, with your great description, so I really encourage you to put together these cases, and I look forward to those case reports and publications. So thank you very much. Now, Dr. Vincent, since it's 9:20 a.m.
Yes.
here, I have to go back to my dialysis unit and see more dialysis patients.
Sorry.
Yeah.
Apologies.
Thank you, Professor Kalantar. That was great presentation. And sorry for taking up your time. You are quite busy. Sorry, and thank you.
Thank you very much. It was such a great pleasure and honor. I feel that I'm so honored and much more honored than talking in a big conference in US or Europe. Thank you very much for inviting me. Have a nice day. Best of luck. Thank you.
Thank you. Appreciate it. Thank you very much.
A lot of information and a lot of new stuff and something that we can actually practice down here as well. Thank you so much, Dr. Kam. We'll keep in touch.